Hello, everyone, and thanks for joining us for today's webinar from the Institute for Research on Poverty. I'm Dave Chancellor, and I'll be your host today. I'm pleased to introduce Shannon Monnat, who's an assistant professor of rural sociology, demography, and sociology at Penn State. And Dr. Monnat will be giving a presentation today called Deaths of Despair, Drug, Alcohol, and Suicide Mortality in Small City and Rural America. So just a few announcements before we get started. First, we want to acknowledge the Office of the Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services for their support of this webinar series. However, the content of this webinar doesn't necessarily represent any positions of ASB or IRP. We are recording today's webinar and plan to have the video available on the IRP website and on IRP's YouTube channel by the beginning of next week. And today we'll save the final 15 minutes or so for Q&A, and we encourage you to submit questions for Professor Monnat in the Q&A box at the bottom of your screen throughout the webinar. So with that, welcome Professor Monnat, and I'll turn it over to you now.
Thanks for having me, Dave. I'm happy to be giving this presentation today. As Dave mentioned, I am a demographer and a sociologist, and I've been interested in health disparities, especially how health is affected by the context of our everyday lives, the places where we live, work, and interact with others. And before 2014, the extent of what I really knew about opioids and sort of drugs in general was kind of informed by TV shows, mostly shows like The Wire and Justified, which was set in Harlan County, Kentucky, and dealt with the opioid crisis in a small rural area there. But I didn't think much about spatial variation in opioid misuse, or really view this as a demographic issue back then, but I certainly do now, and that's some of what I'm going to be talking about today. So I just want to start by acknowledging my funders and say that the views expressed in this presentation are mine and not necessarily those of these funding organizations, but I certainly thank them for their support. So just a brief outline of what I'm going to go through today. Start off by talking about trends in drug, alcohol, and suicide mortality, these sorts of deaths of despair, and then discuss a little bit the demography of these types of mortality, how they vary across different demographic groups and across different spaces and places in the US. Then I'm going to move into a brief discussion of how we got here, including both what I'm calling the spark of what prompted especially high rates of mortality during this particular time, and also the underlying kindling, the sorts of processes and conditions in certain places that have set the stage for not only increased opioid addiction, but also increased rates of alcohol-related mortality and suicide mortality. But I'm going to finish up by talking a little bit about what I view as some important strategies or steps for combating these deaths of despair. And I should note right now that this presentation is not just about small city and rural America. It includes the whole US. But because drug, alcohol, and suicide mortality rates are higher in small areas and many rural areas, those tend to be a lot of the places that I'm going to emphasize during this presentation. So here I show the increase in the number of deaths that are attributable to drugs since 1999. Unintended drug-induced deaths in the US have more than tripled since 1999, with nearly 50,000 deaths due to drugs in 2015 alone. And the death rate from drugs has climbed at a much faster pace than other causes of death in the US, with a growth trend that's now similar to the HIV/AIDS epidemic in the US during the late 80s and early 90s. Here I add deaths from suicide, and you can see suicides have also increased by about 50% since 1999. Now, although suicides by intentional drug overdose are included in this category, as we're going to see in a minute, drug overdoses actually represent a very small proportion of suicides. The majority of suicides are caused by self-inflicted gunshot wounds. Finally, the purple line here shows the increase in deaths from alcohol-induced causes. These sorts of deaths, especially deaths from cirrhosis of the liver, have increased by about 70% since 1999. And these deaths have increased not only in number, but also in rate. So even when we account for age of population, death rates have increased from these three causes as well. So together, drugs, alcohol, and suicide were the direct cause of death for over 127,000 people in 2015 and for over 1.5 million people between 1999 and 2015. This is another way of looking at the increase in these three types of death over time, but here I break down suicides by whether they were intentional drug overdoses, suicide with a firearm, or suicide by some other cause. And here we can clearly see that suicides by firearm make up the largest contribution to suicide deaths, and suicide by drug overdoses are comparatively smaller. If we go ahead and add deaths where drugs or alcohol were not listed as the direct cause of death, but were noted on the death certificate as contributing to the death in some way, then the numbers get even higher. So in 2015 alone, drugs, alcohol, or suicide contributed to over 157,000 deaths in the US. And from 1999 through 2015, which is the most recent year for which these data are available, they contributed to nearly 2 million US deaths. So if we consider drug-related deaths, which drugs are contributing to these deaths? Well, this graph shows all deaths where drugs were listed as a contributing cause. And here we see that the specific drugs involved in most drug-related deaths are actually unspecified or unknown. So when the medical examiner identifies the cause of death and identifies it as drug-related, he or she sometimes does not know or is able to identify which drug was actually involved in the death. But among those that are identified by the medical examiner, opioids are the primary contributor to drug-related deaths. Opioids include heroin, of course, prescription opioid painkillers or analgesics or narcotics is another way of referring to them, synthetic opioids like fentanyl and methadone. Opioids, even though the US makes up less than 5% of the world's population, we consume over 80% of the world's prescription narcotic opioids, including 99% of its hydrocodone, which is a prescription opioid painkiller. Synthetic opioids, as I mentioned, include fentanyl, which is a really highly potent and deadly opioid. It's 50 to 100 times more potent than morphine. And we can see from this chart a major increase in the share of drug deaths involving heroin since 2010. And a major increase in synthetic opioid-related deaths, mostly fentanyl, since 2013. Although they get less attention from the media and from politicians, the percentage of deaths that include benzodiazepines as a contributing cause have also been increasing. Benzodiazepines are sedatives. They're commonly used to treat anxiety, panic disorders, and to help with sleep. So the countervailing message in the media has really been that addiction does not discriminate. We hear that a lot. And though that's technically true, it's true. It's also true that certain demographic groups are at higher risk than other groups, and that rates of death from drugs, alcohol, and suicide are higher among certain demographic groups and in certain geographic areas in the US than others. And this is important because it has implications for how we should think about prevention and treatment. So now I'm going to go through some demographic trends in drug, alcohol, and suicide mortality rates. So here I show rates for drug-induced, alcohol-induced, and suicide mortality rates by sex and by race for whites, blacks, and Hispanics. Male trend lines are shown in blue and female trend lines are shown in red. And here we can see that until about 2007, drug-induced mortality rates were highest among black males. Since 2007, though, white males have had the highest drug-induced mortality rate. Although white females had a relatively low drug mortality rate in the late 1990s and early 2000s, it's really surged since that time. And white females now have a higher drug mortality rate than both black and Hispanic females and Hispanic males. When we look at alcohol-induced mortality rates, we actually see, interestingly, a decline for blacks and Hispanics. But whites, both males and females, are the only groups to experience increases in alcohol-induced mortality rates since 1999. I want to point out that these graphs don't include American Indians, for which rates are incredibly high. American Indians have the highest alcohol-related and alcohol-induced mortality rates of any of the different demographic groups, but they're not shown here. For suicide, we see that the only increases have been among whites. Again, both males and females, with the largest increases shown among white males. Rates for blacks and Hispanic males and females have remained fairly stable since about 1999. So it's also important to consider how mortality rates vary by age group. Drug-induced mortality rates are lowest for the 15 to 24 age group and have somewhat leveled off since the mid-2000s for that age group. Rates are the highest for the 45 to 54 age group, but the next two cohorts down, the 25 to 34 and 35 to 44 age groups, are quickly catching up. The trends look a little bit different when we look at alcohol-induced mortality. So for alcohol, you can see from the orange line, the 55 to 64 age group has the highest mortality rates. And that really makes sense because the majority of those deaths are due to cirrhosis of the liver. And the risk, of course, with cirrhosis increases with years of heavy drinking. It is noteworthy how much of an increase there's been in mortality for that age group since 2008. Those are the baby boomers, and the trends suggest that they may have been a group of heavy drinkers in young to middle adulthood. Turning to suicide, like drug-induced mortality rates, suicide rates are also highest among that 45 to 54 age group, followed closely by the 55 to 64 age group. But suicide mortality, like drug mortality, has increased for all age groups since 1999. It's also important to consider how these rates vary spatially. So these graphs show just drug-induced mortality rates by age group and by metropolitan status, with the purple line representing large urban areas, the small line, the orange line representing small urban areas, and the green line representing rural areas. Large urban counties are those that are located in a metropolitan area of about 1 million or more residents. These are places like Los Angeles County or San Francisco County or Washington, D.C. or Philly. And then small urban counties are located in metro areas of less than 1 million residents. So these are places like New Haven, Connecticut, or Albany, New York, or Dayton, Ohio. And then rural are all of the other counties that are not located within a metropolitan area. And so here we can see that for this 25 to 54 age range, that group captured in the first three graphs, drug mortality rates are now higher in small urban and rural counties than in large urban counties, even though that was not always the case. I don't really have time to show the trends for suicide and alcohol, but in both of those cases, rates are higher and have risen faster in small urban and rural areas than in large urban areas. So let's take a look at how the geography of drug mortality has changed in the U.S. since the 2000s. So early on, from 1999 through 2001, many of the states that are in the top 10 of highest drug mortality rates are kind of among the most urban states in the country, including Washington, D.C., and Maryland, Arizona, Connecticut, New Jersey. But by 2013 to 2015, most of the states with the 10 highest drug mortality rates are among the least urban states in the U.S., including West Virginia, Kentucky, and New Hampshire. The cities were driving high drug-related mortality rates in the 2000s, but less urban areas are driving high rates now. This map shows the distribution of high versus low drug, alcohol, and suicide mortality rates by county. So these are all deaths pooled that included drug, alcohol, or suicide as a contributing cause. And these represent ages 25 to 64. The light yellow counties are those with the lowest rates, and the dark red counties are those with the highest drug, alcohol, and suicide mortality rates. So what we can see from this is that rates are comparatively higher in certain places in the country than others. So they're higher, for instance, in New England, certainly Appalachia, the upper Rust Belt area, or the industrial Midwest, I should say. Oklahoma has really high rates, thanks in large part to large American Indian populations that struggle with alcohol and drug addiction. The desert Southwest and Mountain West also have very high rates, as do Northern California and the Pacific Northwest. So what we can see here is that although addiction may not discriminate, there are clear trends, spatial trends, in where rates are high versus where they're low. So how did we get here? So I suggest that the stage has actually been set for quite some time, and we probably would have seen increases in drug, alcohol, and suicide mortality even without the major increases in opioid mortality that we've experienced over the past decade. But the widespread availability of prescription opioids, followed by the ease of accessing cheap and potent heroin. These are really the spark that kind of started the fire that we're now immersed in. So in any discussion of opioids, I think it's important to understand just why they're so addictive. So the morphine molecule is the main ingredient in opioids, and it fits lock and key into these receptors that we have in our brains and spines and gastrointestinal tracts. And these mu receptors are designed to create pleasure sensations, and they're especially receptive to the morphine molecule. So when the drug attaches to these receptors, what the drug does is reduce the perception of pain. But the mu receptor also combines with endorphins to give us those sorts of glowing feelings that we get when we fall in love or hold a baby or pet a furry puppy. And those morphine molecules, they overwhelm the receptors and create a far more intense euphoria than anything we can come by naturally. But that's not the only issue. The other thing that happens is that pretty soon after using these in high doses over the long term, the body begins to shut down its own natural production of endorphins because all these unnatural ones from the opioids are telling the body it doesn't need to produce its own. So unfortunately, when somebody tries to stop using opioids, it can have a pretty negative impact on their bodies, including excruciating pain, certainly diarrhea, sleeplessness. And that's when physical dependence can really occur, when the person experiences these withdrawal symptoms when they stop use. In many ways, Sam Quinones argues that opioids are really the poster child for the American age of excess because they're sort of perceived as a quick fix. No amount of them is ever enough, and they create higher tolerance the longer one uses them. And that's actually one of the biggest problems, because when a person kicks a habit, they sometimes go back. They often go back. And when they do, the body can no longer tolerate the dose it used to tolerate, and the user can overdose and die from depressed respiration. Opioids just simply don't follow the rules of other drugs because they fight really hard to stay in our systems. Opioids were not always widely prescribed for everyday chronic pain. They were once reserved mostly for traumatic injury victims and terminal cancer patients. But beginning in the 1990s, pain advocates pushed to get pain recognized as the fifth vital sign in the US, that argued that pain is just as important to measure as body temperature and pulse rate and respiration and blood pressure. And the thought was really that doctors should ask patients about their pain and medicate them for it. And so now when you go to the doctor, inevitably the doctor asks you, are you in any pain? Even if you just went there for a general physical visit. In 1996, Purdue Pharmaceutical Company introduced an extended release oxycodone product to the market, Oxycontin. Purdue heavily marketed Oxycontin for everyday pain in a way that was really unprecedented for a Schedule II drug. Purdue encouraged their sales reps to aggressively market to physicians, especially in geographic locations where other opioids were already being heavily prescribed. So places with a lot of manual laborers, mining areas like Appalachia in the Mountain West, and places with retirees like Florida. Purdue claimed that Oxycontin was less addictive than other opioid products, and that it didn't provoke withdrawal symptoms because its time-release formula would allow for a delayed drug absorption. So that made physicians comfortable in prescribing it for a wide range of chronic ailments, really from back pain to headaches to even menstrual cramps. What we know now is not only was Oxycontin far more potent than other painkillers, but addicts quickly learned that they could crush, liquefy, and inject the tablets to experience the full dose at once. So as I mentioned, before 1990, physicians in the US really took a minimalist approach to treating chronic non-cancer pain with opioids. But now opioids like oxycodone and hydrocodone are prescribed to about 1 in 25 adults for the treatment of chronic pain. And about 25% of non-cancer patients who receive opioid prescriptions over the long term struggle with addiction. I think it's important to note the U.S. has dealt with opioid problems a couple of other times in its history, but the current extent of opioid addiction in the U.S. is unprecedented in the country's history and really unparalleled anywhere in the world. So I think it's also important to note that some physicians remained skeptical about using opioids to treat chronic pain, and they remained fearful of addiction risks. So it wasn't like doctors en masse were suddenly prescribing these rampantly to everybody. But some doctors did begin prescribing very liberally, and then others viewed the increased demand for prescription opioids as a sort of entrepreneurial opportunity. And that's where pill mills really came in. So these are places where doctors doled out prescriptions for Oxycontin and other opioids, kind of like ATM machines, often without much or any diagnosis or follow-up. Patients would line up, they'd pay several $100s in cash, and they'd leave with hundreds of pills, some of which they may have used themselves, but most of which they would sell back home. These clinics first popped up in places like Ohio, Kentucky, West Virginia, and then they spread across the country like fast food franchises, really. They were especially prevalent in small cities and towns. Pretty soon, these Appalachian states, Ohio, Kentucky, West Virginia, they caught on to these pill mills and they started shutting them down and changing their state laws, including enacting prescription drug monitoring programs. But prescription laws were far more lax in Florida in the early 2000s. There were no prescription drug monitoring programs there. So in the early 2000s, pill mills really ran rampant in Florida, and people traveled from all over the Southeast to get pills. In fact, the people traveling from the Southeast down to Florida nicknamed Interstate 75 the Oxy Express. And at one point in Broward County, Florida, there were actually more pill mills than McDonald's, if you can believe that. So earlier we saw this graph showing this uptick in the percentage of drug-related deaths that involve opioids. And I've been talking about prescription opioids so far, but we especially see a major uptick in heroin in synthetic opioid deaths since about 2010. Some experts suggest that folks who were addicted to prescription opioids began to have more difficulty accessing those opioids as doctors kind of caught on to the problem and states enacted prescription drug monitoring programs. So some of the experts argue that these people turned to heroin. Now, heroin is riskier than prescription opioids because batches are inconsistent. They can be laced with deadly substances, including fentanyl. And other experts argue that while that may have happened for certain groups of people, there are also some demographic groups who never got hooked on prescription opioids but just turned straight to heroin. So I think it's important to distinguish the percentage of drug overdoses that involve heroin versus prescription opioids and how those vary across different age groups. So what we see here is heroin mortality rates, or the percentage of deaths involving heroin, is much higher among the young adult, the age 25 to 34 age group, than among the older adult age groups. Heroin use is more common among young adults than among older adults. And so when we break down these overdose deaths by age group and we examine the drugs that were involved, we see that prescription opioids are a much bigger contributor to overdose deaths among the 45 plus age group, whereas heroin is a much larger contributor to the younger age group. The fact is, many physicians are still quite hesitant to prescribe opioids long-term to young, seemingly able-bodied adults. So what happens in some cases with young adults is they might receive an opioid prescription from a dentist for wisdom teeth removal, or they might be prescribed opioids from some surgery or an injury. Sometimes, well, they might have only needed a week's worth. The doctor may have given them a month's worth. They might take them all, they might get hooked, and then they might not be able to get opioids from a physician long term. But some young adults get hooked on opioids just by experimenting with their friends. Their friends have pills, they take some, after a while they get hooked, but prescription pills are expensive and heroin is very cheap, so it's easier to access. In fact, here in Pennsylvania, heroin is cheaper than a 6-pack of beer. So how do we get here beyond the spark? So the widespread availability of opioids, as I suggest, is really the spark. But deaths from other drugs have also increased, as have suicides and alcohol-induced deaths. Drug, alcohol, and suicide deaths are not a random collection. They often derive from depression, hopelessness, chronic pain. Especially striking and important, I think, for this discussion is that drug, alcohol, and suicide mortality has increased during a period of declining mortality for other major causes of death, including heart disease, diabetes, motor vehicle accidents, and most types of cancer. So while opioids may have been the spark, I argue that social, economic, and political factors have been kind of the kindling. This is laid out really nicely in Sam Quinones's book Dreamland. If you're not familiar with this book, if you haven't read it, I highly recommend. I've read this book 3 times now. The first time I knew very little about opioids. The second time I was beginning this research. Then the third time I was trying to understand some components of the problem a little bit better. But what Sam argues in this book is that to many politicians and to many folks in the media, this epidemic, as they call it, really seemed to come out of nowhere. But Sam Quinones shows that prescription opioids and heroin and problems with alcohol and mental illness didn't just appear in small town and rural America overnight. He says this was not new. It had been happening for 15 years, and there was more to it than drugs. It was connected to the conflation of big forces, economics and marketing, poverty and prosperity. Forgotten places of America acted like the canaries in those now shuttered Appalachian coal mines. Just no one in the country listened much until more respectable types sounded the same alarm. Ultimately, the U.S. despair problem is driven by this complex interplay of globalization, industrial restructuring, rising income inequality, and economic policies that have really emphasized the market over collective social safety nets. In 2 other recent books, J.D. Vance and sociologist Arlie Hochschild described long-term economic decline and cynicism, anxiety, stagnation, slippage among largely working-class white communities. In writing about manufacturing loss and economic decline in Ohio, J.D. Vance writes about these years of decline in the blue-collar economy. And the Great Recession and the not-so-great recovery that followed, suggesting that those things kind of hastened the downward trajectory of this once vibrant place. But it was about more than the economy, that there was something more spiritual about the cynicism among folks who lived in the community. Similarly, Arlie Hochschild wrote about how the people who she talked with in Louisiana had felt like they were on shaky economic ground, and they told stories that really resonated of unfairness and anxiety and stagnation and shame. Recently, the economists Case and Deaton have focused on rising morbidity and mortality among middle-aged whites, especially those without a college degree, and they've noted that declining life expectancy for that group is mostly attributable to drug overdoses, but also suicide and cirrhosis of the liver. And they've attributed this to a decline in wage returns to experience, specifically age. As we're in the labor force longer, we get older, we should be earning more income. But that largely hasn't happened in the last couple of decades. So declining wage returns and declines in labor force attachment have had these cascading effects on relationships and health, according to Case and Deaton. So in order to make the case that this economic and related social distress are drivers of these deaths of despair, mortality rates would need to be higher in places with more relative economic disadvantage. So this bar chart shows the average county level drug, alcohol, and suicide mortality rate by level of economic distress. And economic distress includes a collection of variables that I've identified at the bottom of the slide. And what we see here is that counties with the least economic distress, they're captured in quartile 1. They have the lowest average drug, alcohol, and suicide mortality rates. Counties with the highest economic distress are captured in quartile 4, the deepest red. And indeed, what we see is that the average drug, alcohol, and suicide mortality rate is highest for counties in the top half of that economic distress distribution. And even when we look at each of the specific indicators of economic distress that went into that index, across every indicator, what we see is that the average mortality rate is higher for counties with the highest level of distress, highest poverty rate, disability rate, unemployment, uninsured, single-parent families, and highest percent without a four-year college degree. Those counties all have significantly higher average drug, alcohol, suicide mortality rates than counties with the least distress. Much of the story about the downward slide of especially small cities and towns in places like the industrial Midwest and Appalachia and New England, much of that story has been about losses in manufacturing and natural resource industry jobs like mining and logging, because either no new jobs came in to replace them, or the jobs that did replace the jobs that left are lower paying service industry jobs. So what's happened is that median household income has declined for a large proportion of counties in the US since 1980, and it wasn't all attributable to the recession. About 25% of US counties lost median household income. Median household income declined in about a quarter of US counties between 1980 and 2000. So what this chart shows is that the average drug, alcohol, and suicide mortality rate is much higher among counties where median income has declined. Many people in these communities now earn less income than their parents, and they see an even less bright future for their children. So there's a real sense in these places that the American dream is kind of a scam, and it's no longer realistic for most people. And this isn't something that happened all of a sudden. It's been building for at least the last 3 decades. We also have to consider the role of health promoting institutions. So average mortality rates are higher in places that don't have a large presence of these social capital promoting establishments, religious institutions, civic organizations, churches, community groups, places like the Elks Club or the Lions. These are places that facilitate engagement with your neighbors, that get you out of the house, they increase interaction. Opportunities for that sort of civic engagement facilitate community trust, goodwill, social cohesion, and they sort of increase residents' sense of community belonging. Mortality rates are also higher in counties that are designated as primary health care or mental health care shortage areas. These are places where it's more difficult for people to access necessary physical and mental health treatment. It's also really interesting to look at how mortality rates differ by the racial and ethnic composition of counties. So rates are higher in counties with the highest percentage of non-Hispanic whites versus counties with the lowest percentage of non-Hispanic whites. But the average mortality rate is much lower for counties with the highest percentage of Black residents. You can see from the second column, again, mortality rates are much lower among counties that have the highest percentage of Blacks. So despite this perception, as well among some politicians that immigrants bring drugs into the community, mortality rates are no higher among counties with the highest percentage of immigrants than they are among counties with the lowest perception of immigrants. And the other thing that you can see here that's really striking is that counties with the highest percentage of American Indians have significantly higher drug, alcohol, and suicide mortality rates. So this came from a research brief that I recently published with the Carson School of Public Policy. And what we can see from this chart that breaks down mortality from drugs, alcohol, and suicide by race and sex between 2000 and 2014, what we can see is not only are drug, alcohol, and suicide mortality rates higher among whites than among Blacks, but that they've increased among whites while dropping among Black and Hispanic males. Rates for Black and Hispanic females are quite low and have changed little. So this is a demographic and epidemiological conundrum, right? Given that Blacks fare collectively worse on several key health measures and face considerable economic disadvantage. So lower drug-related mortality rates may be related to physicians being less likely to prescribe opioids to Black patients, but Blacks also have lower alcohol-related and lower suicide mortality rates and lower rates of depression and anxiety than whites. So what's going on? Well, the Pew Research Center regularly conducts surveys about optimism, allowing for these sorts of comparisons over time. And in the survey I show here on the left of the screen, they ask people ages 25 to 54 to rank their standard of living compared to their parents. What they found is that whites without a college degree are far less likely than Blacks or Hispanics without a college degree to indicate that their standard of living is much better or even somewhat better than their parents. Moreover, the perception of doing better than their parents has drastically fallen off for whites since 2000. So we really need to think about reference group theory here. When we think about how we're doing in life, we often compare ourselves to our parents. This means that many non-college educated whites are comparing themselves to a generation that had more opportunities than they had, a generation where folks without a college degree could get decent paying jobs, even if those jobs were often dangerous and very physically demanding. They came with a sense of satisfaction and a decent paycheck. Blacks and Hispanics, on the other hand, are comparing themselves to a generation that they may perceive as having fewer opportunities. So this means that whites may be comparing themselves to a reference group that leads them to feel worse off about their lives, whereas Blacks and Hispanics may be comparing themselves to reference groups that make them feel better off. So let's take a look at Luzerne County, Pennsylvania as an example county of what I am calling a landscape of despair. The number of manufacturing jobs in Luzerne County, Pennsylvania has declined from over 42,000 in 1980 to less than 19,000 now. And the types of manufacturing jobs available now don't pay as well as the manufacturing jobs that were around 40 years ago. It's important to point out the poverty rate is not the highest in the state. In fact, many of the places with the highest drug, alcohol, and suicide mortality rates are not the poorest places in America. But they're places that are generally worse off today than they were 30 years ago, and that's certainly the case in Luzerne. Median household income has basically remained stagnant since 1980, while the cost of living has increased. Over a quarter of residents between the ages of 25 and 59 are either unemployed or not in the labor force at all. The county suffers from chronic outmigration of young adults, and those who are most likely to leave are those who have the resources to do so. So that just leaves behind a larger concentration of the most vulnerable and disadvantaged young adults. The number of drug overdose deaths there has nearly tripled in the past 15 years. Suicides have more than doubled. What's going on in Luzerne County is much bigger than drugs. And it's a symbol of what's happening in similar counties across the country. In these types of places, jobs and the dignity of work have really been replaced by a sense of hopelessness and frustration and the feeling that America isn't so great anymore and that people in power are only making things worse. I think it's also important to point out that work is a source of status in the US. Our identities here are wrapped up in our jobs, but the working class in our country, people without a college degree, people who work in blue-collar jobs, regularly receive the message that their work is not important and that they're irrelevant and replaceable. And that message is delivered through low wages, declining health and retirement benefits, government programs for which they don't qualify, but for which they must pay taxes, and the seemingly nonstop message that everyone should go to college. So it may come as no surprise that Donald Trump carried Luzerne County, despite the fact that a Republican hadn't won Luzerne County since 1988. Now, these deaths represent only a tiny fraction of those that are suffering from substance abuse and mental health diseases and disorders, and the effects certainly ripple beyond the individuals who die to include families, friends, first responders, service providers, employers. For instance, we're seeing increases in children who are removed from their homes because their parents are addicted to drugs or their parents have overdosed. Workplace productivity suffers when workers are not performing at their best due to drug and alcohol problems. First responders and emergency department personnel are overwhelmed by overdose calls. These are costs to us all, whether or not we know someone personally who is struggling with addiction or mental health problems. I've heard anecdotally that employers in some of the places hit hard by drug use are having difficulty finding employees who can pass drug tests. Sam Quinones, again, the author of Dreamland, has reported on this same issue. And he notes that simply bringing jobs back won't be enough to make these places great again if the residents who live there are not fit for work. These places are going to require massive investments in drug treatment and mental health services and simultaneous investments in long-term prevention strategies. So where do we go from here? Well, I'll state up front that I am not a prevention expert, nor am I an expert about drug, mental health, alcohol treatment. So what I have here is based on the literature, evidence-based research. And I think that any chance at combating this surge in deaths of despair is going to require a really comprehensive, widespread approach that deals with prevention, treatment, and recovery. It can't just deal with one of these. In terms of prevention, efforts at quelling the drug supply have really focused on opioid prescriptions and heroin, and include things like prescription drug monitoring programs and reforming prescribing practices. President Trump has suggested that a border wall between Mexico and the U.S. will reduce the supply of heroin entering the U.S. But recent news stories really show that people are now making synthetic heroin in labs right here in the U.S. Moreover, fentanyl, which has contributed to the biggest surge probably in drug overdoses in the past couple of years at least, comes from China, not from Mexico. So efforts at reducing supply are going to be fruitless as long as demand remains high. So preventing drug initiation is going to be key to reducing abuse and mortality among the cohorts that are coming into adulthood now. In terms of treatment, the most commonly adopted strategy has been to increase access to Narcan, the opioid overdose reversal drug. And that's certainly an important step and an important piece of the overall puzzle. People must be alive in order to recover. But it's only one small piece, and by itself, it's barely going to make a dent in overdose deaths. We're simply not going to Narcan our way out of this. The problem is bigger than opioids. Narcan is only effective for opioid overdoses. Not for benzodiazepines, for instance. Related approaches have included increasing access to substance abuse treatment, including medication-assisted treatment, comprehensive patient treatment approaches. Harm reduction approaches, which don't get enough attention in my opinion, have also shown promise, but they're controversial because they're a set of these strategies that are aimed at reducing the negative consequences that are associated with drug use rather than stopping drug use altogether. They really incorporate the spectrum of strategies for safer use rather than abstinence. Finally, we must remember that recovery is a lifelong project. A person is not cured after treatment, similar to how a person is not cured after having a heart attack or after being diagnosed with diabetes. So to better understand and deal with substance abuse recovery, we should view substance misuse relapse similar to how we view relapse from other chronic diseases like diabetes or hypertension, when people fail to take their drugs as prescribed or don't exercise as directed by a doctor or fail to change their diet as directed by a doctor. So key to this is acknowledging that individuals' opportunities and choices and behaviors don't occur within a vacuum. They exist within the context of larger social structures, family, the economy, education systems, our healthcare system, political systems, and the social safety net. So moving forward, we need to come to terms with the fact that what we are seeing here, it's bigger than opioids. Opioids are a canary in the coal mine. They're here in our face, in the media. We hear about them from politicians. Maybe we even see them in our own families or among our own friends. But the opioid problem is simply a symptom and a symbol of much larger social and economic problems. We need to recognize that health is a function of more than public health policies. Economic and social policies also influence health outcomes. Good economic policy, good criminal justice policy, good social policy are all also good public health policy. Our individualistic go-it-alone attitude in the US is certainly not helping. We're a very individualistic country. Whites in particular embrace this ethos of individualism, which may partly explain such high rates of deaths of despair among whites. When things start to fall apart, going it alone is far less successful than doing it in groups. The idea that we're all in this by ourselves and only the strongest survive contributes to isolation and despair. The reality is that the consequences of deaths of despair affect us all, whether we personally know someone who's dealing with addiction or mental illness or not. This is a population health issue. This is a U.S. economic competitiveness and sustainability issue. And until we're willing to invest the time, energy, and political will into addressing the underlying causes of distress, despair, disconnectedness, folks will continue to engage in harmful behaviors, families and communities will continue to suffer, and the consequences will reverberate to affect us all. So I just want to wrap up by posting some links here in case you're interested in reading more about these deaths of despair and their social determinants. these are all publicly available. And if you're not able to access them all, you can certainly email me. I've provided my email address up there, and I can send them to you individually. And so now I think it's time to take some questions.
Thank you so much, Shannon, for that great presentation. And in that last slide with a number of those publications, I'm going to bring that up at the end of the webinar so that folks can click on those kind of at their as they're available to. So, just a first question. We have a question about sort of how do we contextualize this compared to, say, other other diseases or maybe smoking-related behaviors, obesity-related behaviors. And what do the death rates look like? How do we compare those?
Yeah, so I think one of the really interesting things is when you map spatially where high rates of other types of death are. There are a lot of differences, and so where we see overlap with high rates of drug, alcohol, and suicide mortality and high rates of other types of death, for instance, cancer mortality or heart disease mortality, those overlaps are in places like Appalachia and American Indian majority counties. But there's also significant divergence. So for instance, where most maps are colored dark red, if dark red are the highest rates for mortality, where most maps are colored that darkest red for heart disease mortality, for instance, or cancer mortality or diabetes-related mortality, that tends to be the black belt of the U.S., the southern area with large Black populations. And that is completely opposite of what we see for drug, alcohol, and suicide mortality maps.
Okay. We have another question that I think is interesting. I mean, we talked a lot about sort of the opioids and sort of the increase in those deaths, but what's sort of the explanatory factor between this increase in benzodiazepines? I mean, it's a similar story as
so there have been increased rates of deaths from benzodiazepines, and it's hard to sort of identify why. I mean, some people suggest that it's because people are mixing benzodiazepines with opioids, but also some people suggest that more consumers are just using benzodiazepines. Again, they're sedatives. They're used for sleep, for anxiety, and rates of use of those have increased as well.
Okay.
I have a question here about rural-urban comparison, which I think is a good one. So someone asked, what about the urban to rural comparison? Are whites in cities exempt from the mortality trend? Certainly not. One of the really fascinating things for me when I started this research was that the largest cities have the lowest rates of drug, alcohol, and suicide mortality. And that's the case for whites and for blacks and for Hispanics. So rates are lowest, again, among all three groups in the largest urban areas. What's interesting is that in the most rural areas, blacks continue to have very low rates, whereas rates are very high among whites. So there are these really important spatial comparisons that we need to make, as well as demographic comparisons. And I want to make very clear that rural does not equate to white. Rural does not mean white. About 20% of the racial minority population in the U.S. lives in rural areas. And so, those places are not universally white, and these trends that I discuss are not universally affecting whites.
Okay. The national map that you showed, and I'm actually going to go to it real quickly here. Let's see if we can. And, I just thought that was really interesting. And I'm wondering if, as a demographer, I mean, you talked about this a little bit, but are there sort of particular regional cultural stories that you tell that sort of that you see going on here?
Yeah, so others who have researched the opioid issue, and certainly Sam Quinones, who dug deep into this, points to Appalachia as one area with an interesting cultural story, and that's that was an area that had a large supply of manual laborers, people working with their bodies. And mining companies actually would routinely employ physicians there on staff to prescribe opioids for minors when they were injured so that they would continue to work, so they wouldn't lose productivity. So there's kind of been a long history of opioid misuse in Appalachia, and it was ignored back in the 80s and 90s. So, people often talk about how we're paying attention to drugs now because they're affecting whites rather than racial minorities, but I would argue that we were ignoring it in Appalachia in the late 80s and 90s. When really high rates of drug mortality and addiction and even incarceration were apparent then. We weren't paying much attention to it. New England struck me when I first started doing this research as an interesting area because I always perceived New England as having a relatively good economy, good health, but in the places that have high rates of drug, alcohol, and suicide mortality, what that can really be attributed to are declines in extraction industry jobs. So there used to be a lot of logging in these New England areas. So declines in those jobs and then related declines in paper mills, for instance. The Mountain West also is a heavily mining area, or once was a heavily mining area. So that's part of what's going on there. Some of the first pill mills popped up in Utah, which a lot of people don't know. So that partly explains maybe some of the high rates there as well.
Okay, thank you. We have a data question, especially looking at the sort of social capital indicators, and so what sort of things are you measuring when you're looking at communities and the services they offer, or institutions, civic engagement, that sort of thing?
Yeah, so what I showed here is only a really small piece of what I've been working on more broadly. And without getting too technical here, in regression models, I've examined a number of different institutional and social and healthcare indicators, everything from like the per capita supply of physicians or health professionals who can prescribe opioids, up through whether there are physical rehab facilities available in the community. The one that I showed in this presentation was simply whether the county was a professional healthcare shortage area. But that captures all of these other indicators that I've tried to capture in regression models. On the social institutional end, what I've used is really reflected in Putnam's idea of social capital, his number of civic and religious and social institutions per capita. But I've also ran models where I included the percentage of religious adherence, the actual number of religious facilities per capita, any number of different types of social indicators that I could come across that are available at the county level and available nationally.
So a related question is kind of about isolation, and I'm wondering if you'd talk a little bit about sort of family connections, because I know that in Case and Deaton's work, they've looked a little bit about sort of marriageability of young men and factors like that. Does that play into your story much?
Yeah, I think that social isolation certainly plays a role. I haven't incorporated much about family change, although I could see that being important. One of the problems when you're trying to incorporate a lot of variables into regression models is that they're so highly correlated with each other. So, for instance, family breakdown is going to be tightly related to economic distress, right? So it's hard to tease out the specific contributions of economic distress versus declines in marriage or increases in divorce. But it's pretty obvious from anyone who's been paying attention that these things all interact and work together, that when the economy isn't doing so great, when people aren't feeling like their work matters, or they can't get a job, or their job is not paying them very well, it leads to stress in the family. So that's part of it. And another part of it is that male labor force participation has been on the decline for at least the last 30 years. So larger and larger shares of working age men, especially white men, are out of the labor force entirely. And that does not make for necessarily solid relationships.
Okay. Let's see. So we just had a question come in that's this might be a little bit too recent to measure, but looking at change in drug deaths in states that have legalized marijuana or versus states where it's still illegal. Is there much of a connection there?
I think I might have a slide about this. I cannot remember. I'm looking. No, I did not include that slide. So I did measure this. It's really, yes, it is kind of early to say how much of an effect it's going to have. But one of the things that I can see within the last couple of years is that states that had a medical marijuana law, say prior to 2005, maybe, if I'm thinking about this correctly, their drug mortality rates have not increased as quickly as states that did not have a medical marijuana law as of 2005.
Okay.
So there's
Um, you know,
potentially a promise, but I think we need more data and a couple more years to see what's going on there.
okay. Thank you. So a sort of a second case in Deaton question. We've you said them before, and when they kind of their big paper that came out in 2015 that saw that mortality rates among white Americans were actually on the rise for certain groups, and they've just updated that with information showing that for college-educated whites that those rates are still dropping, but for folks with high school education or less, those rates are on the rise. So, thoughts about that?
Yeah, I mean, I think that fits into the things that I've been talking about today, that the types of jobs that are now available to people without a college degree don't pay as well as those that they could get in the past. So what young people and even middle-aged adults see now as being available to them for work, it doesn't hold even not just the paycheck. So it's not just that these jobs don't pay as much, but the types of jobs that are available now to people without a college degree are often not as fulfilling as the types of manual labor jobs that people could access in the 70s and 80s. So as I mentioned, many of these jobs were very dangerous. People got physically injured. We think about coal mining, for instance. Think about working in industries. These were not necessarily safe jobs. But if you read books where people who have worked in these jobs have been interviewed, what they talk about is a sense of satisfaction that they got from these jobs, that they were meaningful for them. Stocking shelves at Walmart is not necessarily meaningful. It brings a paycheck. Certainly some people can derive meaning from that. But these are not necessarily jobs where people are producing something and feeling as though they are being respected for the work that they do.
So we are just about out of time, but Shannon, I wonder if you have any sort of parting thoughts, how you might wrap this up, or what we might look to towards for the future. So what are you looking at?
So this is part of a much bigger project, again, where I'm trying to understand the characteristics of places that have high rates of drug, alcohol, and suicide mortality. And I think it's important for us to consider this beyond the individual perspective and take a more kind of political economy approach to how we got here, how we got to a place where these types of deaths could be so high and could increase so quickly over the span of a few years. I think it's important to note that we didn't get here overnight. This is a problem that's been building and brewing for a really long time, and we're not going to solve it overnight. And as I mentioned in a couple of slides before I ended, it's really going to take a comprehensive approach to try to bring these deaths down. I think we also need to identify what our goal is when we're thinking about policy. Is our goal simply to reduce mortality rates, or is our goal to reduce the demand for drugs, for instance, or is our goal, to try to increase quality of life and satisfaction among people? Because once we identify our goal, I think appropriate policies might follow from that.
Okay. Well, thank you so much, Shannon, for just a really great presentation today. We appreciate it. And just as a reminder, I'm going to throw that slide up with her publications and those other resources on after we're done here today. So for our next webinar, I just want to invite you to that, and that's going to be on Wednesday, May 17th, coming up, and that's called Weighing the Benefits of a Universal versus Targeted Child Safety Net. And so that'll feature Jim Ziliak at the University of Kentucky Center for Poverty Research and Chris Weimer at Columbia University Center on Poverty and Social Policy. And we're going to hear about two very different policy approaches sort of aimed at improving the child safety net. So Chris Weimer is going to discuss a plan for a universal child allowance that he and a group of other poverty scholars have been working on. And then Jim Ziliak will talk about a kind of proposal aimed at targeting benefits that would convert the non-refundable child independent care tax credit to a refundable credit that would work in tandem with the EITC. So I think that should be a really interesting discussion. I'd encourage you all to register just by clicking on that hyperlinked title there. And so with that, Shannon, thank you so much, and we just really appreciate your time and sharing your work with us today.
Thank you for having me. I'm happy to have been here. And for any of you who have questions that I wasn't able to answer, please feel free to email me and I will try to get to them.
Okay, thanks so much. So long.